Welcome to the Ticktective podcast, a program of the Bay Area Lyme Foundation, where our mission is to make Lyme disease easy to diagnose and simple to cure. I'm your host, Dana Parrish, and I'm the co-author of the book Chronic, and I sit on the advisory board of Bay Area Lyme Foundation. This program offers insightful interviews with scientists, clinicians, patients, and other interesting people. We're a nonprofit based in Silicon Valley, and thanks to a generous grant that covers 100% of our overhead, all of your donations go directly to our research and prevention programs. For more information about Lyme disease, please visit us at bayarealyme.org. Dr. Elena Frid is a neurologist and a clinical neurophysiologist who specializes in infections that cause autoimmune disorders with a clinical interest in autoimmune neurology. She sees patients with complex chronic illness in cases of Lyme disease, co-infections, children with PANS and PANDAS, and autoimmune conditions resulting in various neurologic complaints. She uses cutting-edge diagnostic tools and her deep clinical expertise to make these appropriate diagnoses. Dr. Frid attended Robert Wood Johnson Medical School and went to North Shore-LIJ Healthcare Systems, which is currently Northwell, where she completed her residency in neurology and her fellowship in clinical neurophysiology. Hi, Dr. Frid. I'm so happy to see you today.
Hi, Dana. How good to see you.
It's been like 3.5 years since we've seen each other in person. So
I know you've been in California.
Yes. I'm back now, and I am going to hunt you down, and we're going to get together in New York City soon.
I would love that.
Yes, me too. So thank you so much for doing this. You know, you're really one of the top experts that I have ever known who treats children. You're a neurologist, you're a neurophysiologist. You are so highly trained and highly specialized and sought after for kids, for adults with neuropsychiatric issues related to infections, with other kinds of neurologic issues, neurodegenerative things, autoimmune things, like the whole gamut. And I thought, if you don't mind, we could just start talking about kids. What is going on with kids with Lyme and other kinds of tick-borne diseases and other infections? Just tell us like a little bit about what PANS and PANDAS are, what you're seeing, and what we should expect.
Right. So in terms of PANS and PANDAS, as I guess your listeners know, or I hope they know, it is basically an infection, not a specific infection. We'll talk a little bit about that further on. But let's say it's an infection or an environmental toxin that triggers a patient to basically create anti-neuronal antibodies, which I explain as antibodies are soldiers that fight off infections in our body. Everybody has them. And there is a patient population, both in kids and adults, where your own immune system basically gets confused and makes antibodies or soldiers against itself in a setting of PANS and PANDAS, or what I really like to call it autoimmune encephalitis. These antibodies attack your own nervous system, specifically the central nervous system. And we name these disorders based on the location or part of the body or organ system that the antibodies are attacking. So in the case of different types of encephalitis, it's different parts of the brain that are attacked. The reason why I don't love the classification of PANS and PANDAS, because it's very concrete. It's acute and onset. Kids have to have tics, kids have to have OCD. But in some instances, I see patients that it's gradual in onset, it's insidious, and it takes weeks or sometimes even months to peak. And so they don't classify into the category of PANDAS, for example, because it's not acute, it's not overnight, it's not a snap of a finger, and the kids kind of go from good to bad.
I see.
Yes. So in terms of what can trigger these conditions, a lot of the times it can be infections induced, which means that a child has been exposed to infection. With PANDAS, it's commonly strep. But in PANS, it can be other infections, communicable like mycoplasma. It can be candida or yeast. It can be environmental toxins. It can be viruses, Epstein-Barr virus, COVID, other viruses that basically triggers the immune system. And why do these patients actually have this trigger? Well, one of the theories is that in some instances, the bug that's kind of you're exposed to looks very similar to your own DNA, and so then your body doesn't know the difference between the bug and your own immunity or your own, let's say, brain tissue, and so then it creates these soldiers that don't know who they're fighting.
I
So
see.
that's one theory as to why people develop, like one child will develop it and another child won't.
Okay. When you said tics and OCD, those are two symptoms that can present. What is the general breadth of symptomology because, for example, I have friends who have children with PANS, as you know, because I've sent you so many patients over the years. And for some of them, it's been a light switch. It's been both, actually, the slow boiling frog, as you describe it. Also, it's been the light switch where you have this healthy, very normally functioning child with normal moods and happy, healthy kid doing well in school. All of a sudden, they get some kind of immune hit, say it's Lyme or another infection, and it's like a light switch went off and they turn into severe, claustrophobia. They don't want to leave their room. They don't want to be touched. They're screaming at their parents where they were once crazy about being with their families. They don't want to go to school. They can't operate in school. They're throwing things. I mean, I think people that haven't experienced this and don't know about it don't understand what this is like. And I'm just wondering, like, from your point of view, is that, when I'm describing, am I just talking about extreme cases, or is this stuff that you see kind of every day?
This is what I see every day. I do see different breadths of these cases where there is an instance where the child, goes from good to bad and stays bad, kind of ongoing. And then there's other kids who will have instances like in the morning, he doesn't do well, trouble to go to school. But then when you get him out of the door, he's fine and he can keep it together at school. But then when he comes home, things are tough again.
What do you make of that? What is that? I've seen that. I'm so confused about what do you make of that?
I just think that it's the level of severity of their clinical symptoms. Mm-hmm. And what happens is I would call these cases probably mild to moderate.
Okay.
And they're able to subside their symptoms, just like an OCD case where they have to do counting or something like that, and they can stop it, but then it kind of comes back with a vengeance because they can't stop it forever. So they're keeping it together in school, but then when they're comfortable at home with parents and siblings, they can't hold it together any longer.
I see. Where do you start when you see a child like this? Where do you begin as a clinician to figure out what is the best course of treatment? Are there good treatments, and what do they look like?
So I think a lot of my patients do come in from the psychiatrist, and just to note, the child will see usually a pediatrician who will refer them to a psychiatrist, and then the psychiatrist would have tried different medications to improve their clinical symptoms. And what at least I've heard from the psychiatrist or seen in my practice, that majority of the kids are able to be aided if they just have pure OCD, let's say, if they just have a pure psychiatric disorder. Probably 80 to 90% of kids will respond to the psychiatric medications or the interventions that the psychiatrist has provided.
Yeah.
However, if it's like an infectious component, an autoimmune component, these kids are usually not helped by the psychiatric medications. And often what will happen is that actually the psychiatric medications may make them worse. Not all the time. Sometimes they just won't help, but sometimes they will actually exacerbate the clinical symptoms, so the child cannot even tolerate those medications. And these are the kids I would start thinking about, is there an underlying medical problem that's causing the symptoms? So when they do come in, we usually do some blood testing, which would entail looking for infectious causes, usually done through both a regular lab and a specialty lab. Specifically for tick-borne infections, as I'm sure you've talked about it on your show many times, the labs that are available are often not sensitive enough.
Yeah.
So that
It's important though that to hear it from you. Like I don't talk about that much because it's not everybody that I'm speaking to has clinical expertise like you. So I'm really interested in how do you work the kids up, specific labs that you like, and just also if you could rattle off the kinds of tick-borne infections that can cause PANDAS, because I think parents literally don't even know, beyond Lyme, right? That's a big one that we hear about a lot. I think they don't know about some of the other ones. Maybe you could just mention some of the big ones.
So specifically kind of to link the type of infections and the testing, in terms of Lyme, often, when parents are literate in this because they've had family members or someone recommended, they'll ask their pediatrician to check for Lyme. However, a regular blood test that a mainstream pediatrician would run can often, up to 50% of the time, come back negative. And that's just because the testing that's available is not sensitive. So what we do is, and that gives a false sense of security to the parents, to the pediatrician, that we ruled out this problem. And so we need to move on to the next thing. And often, if nothing else comes back abnormal, right, you go to the psychiatric route. But when they come into my office, I want to make sure that we're not dealing with Lyme and co-infections. And some of the co-infections that are very prevalent would be Babesia, Bartonella, and those three I always, Lyme, Babesia, Bartonella, I always check through specialty lab, because if the patient pops up positive for those, it would change my management. I would treat them in a different way. I would pick different medications to address these problems. There are other tick-borne infections like Ehrlichia, Anaplasma, tularemia, not specifically tick-borne, but I always check kids for Mycoplasma. I always check kids for strep. So these are the type of things, just to name a few, you start looking at. Also, kind of taking inventory of what does your kid like to do? Have they been on a hiking trip, or were they in camp this summer, and then they came back and September, October was really tough at school, and then all of a sudden they got a virus, and then they can't get to school at all, and things are kind of I call it the snowball effect.
Yeah.
You have one problem, then another problem, and you take him to the doctor. He's never used to go to the doctor. Now he's at the doctor every month.
Yeah.
So those are the things kind of I take inventory from history to show that there's something going on, probably systemic, that's contributing to the psychiatric symptoms or the neurologic presentation. It's all one of kind of the same picture.
So if you discover tick-borne diseases, let's just say that you discover Lyme and Bartonella in a patient, which is probably pretty common, and it's certainly common for me to hear about those. Where do you begin with treatment? And also, excuse me, can you clarify, just for the general public, that these infections can be chronic? Because I think there's a lot of misunderstanding that these are easy to diagnose, easy to cure, easy to treat. And that is just simply not the case. So I want to hear your experience and what you think about that.
No, I completely agree with what you're saying. I think that what becomes a problem is when people have they have recurrent exposures that they're not aware of. So meaning the child or the person has had, let's say, multiple tick bites throughout their lifetime, but then the one that they had a month ago all of a sudden has causing them clinical symptoms. So you have a buildup of this insult to your immune system over the years. And so that becomes harder to treat. That's where 2-4 weeks of antibiotics does not work a lot
Yeah.
of the times.
Yeah.
That's one. Two, you can have, as you just mentioned, more than one infection in one patient.
Yeah.
Again, a big problem because you're an insult to your immune system. That's more than just one bacterial infection, and patients cannot get over it in a month of worth of treatment, or your immune system will take care of it on its own. It may have taken care of it on its own the first, 1, 2, 3 times or multiple times that you've had exposure, but now this exposure where you're having symptoms, most likely, it's been too much for your immune system, and you need to do something that's stronger, meaning taking antibiotics, and it could be other things that I'm sure we'll cover some of them here today.
Sure.
But the point is that the perception of, well, my friend had Lyme and they got 2 weeks of doxy and they're
Right.
all better. Every patient is different. Someone can have one dose of an antibiotic for a urinary tract infection, and another person is in the hospital for 10 days
Great
treated
point.
with IVs.
It's a very good point. You're absolutely right. And I'm one of the people who got the early treatment within 5 days, and I still went on to have heart failure. I got 3 weeks of doxy, the maximum that I was allowed to have. And, over the course of 5 months, I deteriorated and eventually landed in heart failure. And the fact that any doctor that I saw during this period, which I saw about a dozen, kept insisting that it couldn't still be related to the tick bite when it was completely healthy before, living my best life, prime of my life, all the good things, is so ludicrous. And it's just such a strange dogma around, like, nobody argues that TB is chronic. Nobody even argues now that COVID, very few people argue that are actually medically literate and scientifically honest that COVID is chronic. COVID can be also chronic, and it's, you're finding in organs all over the body. That's already been published and published and published. So I think that it's important to hear you talk about these things. And is it the case that the infections actually go into the brain, cross the brain-blood barrier, or is it the immune response that creates the inflammation?
I think it's both.
Uh-huh.
And that's why it's so hard to treat. I think that, well, Dr. Alan McDonald, decades ago has identified that you do have these infections chronically in the brain.
Yeah.
They actually bore in and they do sit in the brain. And then there is also that break in the blood-brain barrier, inflammation, and autoimmune response that causes the clinical symptoms. And that's why in many instances you have to treat both.
Interesting. Okay, so treatment. So we talked a little bit about antibiotics and having to give sometimes extended courses of antibiotics, which I think is, extremely helpful for some of us. For me, certainly, that was what got me better. What else can you do?
So I guess one of the questions we touched on previously in terms of what treatments, I think antibiotics are a good option. Not everybody can tolerate antibiotics. Not everybody feels comfortable with antibiotics, especially when it's a younger child, or they may have, they may be coming to me when they've already done prolonged courses of antibiotics. So what else can one do? As some of your listeners may know, a lot of doctors will treat in combination with herbal medications as well as antibiotic treatment. And there are studies coming out saying that certain herbal medications will actually enhance the activity of the antibiotic. So that's why using the combination of those things is important.
Can you tell us which herbals you're talking about specifically?
Yes. So, for example, oil of oregano
Yeah.
is often used in combination with, let's say, doxycycline or tetracyclines. Alimed, which is the active ingredient of garlic, has been looked at by a number of physicians, Dr. Mosiani, who is seeing that it's effective with Bartonella treatment. Things like Hutunia, which again is used for Bartonella, Annula, which is used for Babesia, artemisinin used for Babesia, again as a combination treatment with prescription medications. So a lot of the times you use that combination to make the antibiotics work stronger. And in instances where patients cannot tolerate antibiotics, there are two things that, why this happens. One, it could be a Herx reaction, which I don't know if people know. I guess
Probably not. It's a good thing to talk about. Great
okay.
idea. Yeah.
So herxing is when it's basically a name of a condition where it's a die-off effect when you're killing off infection. It doesn't just happen with Lyme or Bartonella or Babesia treatment. It can actually happen with other infections. Strep, it's been described in, where when you start taking your medications, after a day or two, you may feel worse. Depending on the life cycle of the infection, for strep, it will happen within a day or two. For Lyme or Bartonella Babesia, it can happen within days or even weeks after starting medication, because it takes a while for the bacteria to start multiplying and dying off.
Can people have immediate Herx? I've heard this recently, like somebody took one or two, one day of antibiotics, one or two doses, and seem to have like a very significant Herx. Is that possible?
I usually, if somebody takes medication and within hours they're having symptoms or right away, I would usually think it's a drug reaction. It's too soon to be a Herx.
Okay.
If it is a happening after days or weeks, then it can be, especially within days. With Bartonella, sometimes it could be if they have a very strong bacterial load,
Yeah,
they're starting to kill off. And in this instance, you can either back off, lower the dose of the medication, or start very slow and kind of build up so that the patient can tolerate. Another important thing about herxing is I don't classify it as a good thing or a bad thing. I classify it as a tolerable or intolerable. You don't have to have a Herx to know that your treatment is working. But if you do have it and you can tolerate it, meaning you feel achy, or you feel more joint pain, or maybe you feel more irritable or depressed. But if it's mildly worse than your baseline, try to continue. If it's severe where you're becoming debilitated, let your doctor know, and your drug needs to be adjusted.
And how long can that, if you have that really bad neuropsychiatric Herx, which again, I hear about all the time because I hear from a lot of parents with kids who are just beginning treatment, how long can that last?
So usually it should last, again, sometimes hours, ideally, but it can last days or even a few weeks. In my opinion, it should not last for months. So
you're talking about just the Herx. Once you pull the child off of say they're on, Doxy or Doxy and Zit or something, right? And then they stop on a Tuesday. If it wouldn't be crazy for you to hear it's a week for this to calm down. That's not unusual.
I would say days to up to a couple of weeks, 2 weeks. That would be the time frame. Typically, majority of patients, it's within days.
What's the rationale for using multiple antibiotics at the same time when you have people that are diagnosed with chronic infections?
So it's thought based on clinical studies that even Lyme on its own should be addressed with dual therapy, meaning more than one medication. So just doxycycline may not be effective. And sometimes that dual therapy could be an herb, like we talked about, oil of oregano, let's say, in combination. But a lot of times doctors will treat and use 2 antibiotics and maybe an herb to address a specific infection. Basically, they try to use more than one antibiotic to even address one infection.
Yeah.
A lot of times, as we talked about earlier, there'll be more than one infection going on. So there will be, let's say, Lyme and Bartonella. For Bartonella, the treatment plan for that is different than it would be for Lyme. You can overlap one of the antibiotics, but not both. And so the patient may need to be, again, on 2 medications or sometimes even more, depending on what your doctor decides. And that's in order, my concept is, and I think a lot of physicians are doing that as well, is that you need to address all of the things at the same time.
Yeah.
Otherwise, you're not addressing the needs of the patient effectively. So if you have 3 infections, we need to treat the 3 infections at the same time. It's going to be very hard to separate them apart and say, well, we're going to treat the Lyme first, and then we treat Bartonella.
Maybe you integrate slowly. I don't think you have to give,
Right.
10 things at once when you come
Agreed.
from day one. So you probably see a lot of kids with Lyme and Bartonella in terms of the neuropsych stuff. Those are pretty common, right?
Yes.
So where just specifically, for physicians who really want to help these kids, or at least get them started till they could get into somebody like you, what would you say you would start with for an average case of PANS or PANDAS with neuropsych stuff?
So we basically reach for the models of, as you alluded to, tuberculosis. So for Bartonella, we actually use tuberculosis drugs to treat that infection. Dr. Mosiani, who does a lot of research with Bartonella, basically has a number of protocols. Favorite one being a combination of macrolides like clarithromycin, azithromycin, with rifampin followed by rifabutin. So you start with a combination, let's say clarithromycin, rifampin, depending on how the patient's doing. After a number of months, switch them over to rifabutin. I've also seen a lot of kids respond quite nicely to a combination of azithromycin Bactrim, or even cefdinir Bactrim. Cefdinir is going to give you that stronger coverage for Lyme, but also if they're old enough, as we know, doxycycline is not used in kids under the age of 8. You can use it, but a lot of doctors don't like to do that. So if they're an older child, let's say a teenager, you would use doxycycline, combination of Bactrim or rifampin, rifabutin, that family. So Bartonella is tough. But I definitely do use it. You do have to watch out if a child is on psychiatric medication, because macrolides can interact with some of them, causing serotonin syndrome. So you have to get the psychiatrist on board. A lot of times psychiatrists will either lower their psych meds or switch them over, or just, kind of go gradually and monitor them. But again, it's, it takes a village.
It seems important that at least with one of the antibiotics you're using, that they get into the brain. Is that true?
Yes. Again, so this actually segue into the IVIG bit, where I generally start patients on, as I said, a combination of medications. As you said, titrating them up slowly, so they're not started on 3 or 4 drugs at full doses all at once. I usually say, start this in a few days or a week, start this, and then titrate up the doses depending on how they tolerate. Once they're on the desired dose, I want to see some benefit within their clinical presentation within about 8 weeks or so. Let's say 8 to 12 weeks, that they're starting to see, maybe they're not 100%, but you're starting to see some improvement. If we're not seeing improvement, that's when we start talking about, well, is the autoimmune component so strong that we can't just turn it off by treating the infection? Because remember, we said, look, there's an infection, there's inflammation from the infection, and then there could be an autoimmune phenomenon. If the autoimmune phenomenon is not shut off by addressing the infection, then you need to add something to address that. And what is that? So I start with immunoglobulin treatment. That's usually administered IV. and you do that IV 2 days a month. Typically, so you do the large dose. It is a weight-based drug. You calculate it based on how much the patient weighs. You infuse it over a course of 2 days, and they continue taking their medications, meaning their antibiotics or herbs, antimicrobial treatment throughout the treatment with the IVIG. And
Okay.
again, with that, you don't expect, have I seen where after one treatment of IVIG, patients are way better? Yes, that is possible. Is it everybody? No, it's not. Because sometimes you need a build-up of the medication so that it basically retrains your immune system from attacking itself. And it may take time. It may take 3 months, 6 months for patients to start basically improving their symptoms.
So another thing I have heard a couple of times is that sometimes kids get worse after IVIG, and I don't know if it's temporary or not. I don't always hear follow-ups from people that, may email me one time or something. What's your experience there? And is there like a good reason to continue when that happens? Is that to be expected?
So we would need to know, is the worse is completely new? Are they having completely new clinical symptoms?
No, it's sort of like I got some
like a
improvement.
herx.
I just got an email from a mom the other day. Okay.
Yes.
She did a couple of treatments of IVIG, and I think the child is just on doxy with it, but it seems okay because it seems to be a low dose is still barely tolerable. So, and then the child did a couple of weeks or a couple of treatments of IVIG and was doing like, oh my gosh, he seems like he's getting better. And then plummet, the mood came back, all that kind of stuff. And I'm not really sure what to expect with those sort of tumultuous waves and stuff.
Interesting. So again, it's a good topic. So basically, IVIG initially in the first week after the infusion, up to a week, can give you that again, a herx, because you're stirring up your immune system. You're trying to retrain it, you're making the immune system stronger, so you can have a herx reaction. You can also have a wearing off effect of IVIG, where the child does well for a couple of weeks, 2-3 weeks, and then at the end of their IVIG cycle, which is typically a 4-week period, they may have a decline in their clinical symptoms, which means the IVIG is wearing off, and that's a marker that they need to continue.
At what point, or do you ever pull the trigger on something like a steroid? Because that's another thing that parents are often, sort of given that option, where the child is having severe neuropsych stuff, maybe in the presence of also taking antibiotics or being on IVIG, stuff like that. Do you ever give steroids to kind of and does it just shut it down? And does it make things better, or does it have any paradoxical effect?
So I use 3 classes of medications, maybe even more, but as you said, for this abortive effect, it will be NSAIDs, which is non-steroidal anti-inflammatories like Motrin, Aleve. Like, let's say they have a flare, it's an anti-inflammatory, so it helps to reduce inflammation and is very helpful in some patients. Then antihistamines for, again, the inflammatory response, again, can be very helpful for patients. Their prescription strength and over-the-counter, like Benadryl, Zyrtec, those are obviously over-the-counter. And then steroids. So steroids are oral or IV. Oral are obviously much more accessible if you're doing it at home. And in my opinion, I know that there's a controversy whether you can give steroids to with infections or with tick-borne infections, especially if the patient is on an antibiotic or an antimicrobial herb. So you are covering them for the infection. You can use steroids short term. So
if you keep them on antibiotics or antimicrobials,
Yes. So it's okay to do it, to give them a burst of steroids, which again helps to reduce inflammation. In a lot of instances, it is helpful. In patients where it has the paradoxical effect, it's likely because they have the infection that's kind of blooming if you're shutting down or lowering their immune system with the steroid. So, and then obviously there's classes of medications that are psychiatric or specifically antipsychotic. If the patient's very irritable, agitated, those are used, but those are more used in like a longer term. So you would be on it for months, to kind of calm things down. It's the other three I talked about is more, they have a specific issue and you give it to them at the moment and see if they feel better, but they don't have to be on it every single day.
Is it, if you do a steroid, right? If you're in this horrible flare or your child's in this horrible, unmanageable flare, is it like a Medrol pack, like a doctor would give 5 days or so, or is it something different?
Yes, it would be something like a Medrol pack or a prednisone taper, where you taper every day or every other day to, again, weight-based, and then taper them down.
Okay, that's really, really interesting. And do you usually find that it's helpful to give?
A majority of the times, yes. Are there patients that it doesn't work on? Of course. But a majority of the time, one of those three that I talked about would be effective.
Got it. That's so helpful and so interesting to know. In terms of the scope and the breadth of neurologic conditions that you see related to infections, can you talk about those a little bit, including things, memory things? Are there neurodegenerative things that you're seeing, and kind of all the various psych things?
Yes. So in terms of neurologic presentation, I would say the most common things that I hear about would be headaches, dizziness, brain fog. In terms of psychiatric, actually with neurologic, some neuropathies, migratory neuropathies, where they're having pain or weakness, numbness, trouble getting out of bed or going to school. In terms of psychiatric presentation, it would be mood, irritability, depression, sometimes psychosis, OCD symptoms, tics. We talked about that. And from a neurodegenerative standpoint, of course, Lyme specifically can mimic neurodegenerative conditions or demyelinating conditions like multiple sclerosis, even neurodegenerative like Parkinsonism and Parkinson's in that family. Yes, so these ALS, I've seen that, or ALS type of presentations.
Do you ever see these? Do you see these getting better or even resolving with appropriate antibiotic therapy or antimicrobial plus whatever else?
It would depend on kind of how severe the patients are when they present.
The earlier treatment, the better, of course.
Treatment, the better. And yes, I have had younger patients in their early 30s presenting with Parkinson's symptoms or Parkinsonism, and they've resolved with treatment.
Maybe you could tell us one of these miraculous recovery stories, because I think the big thing missing in the world of all these infections is certainly with tick-borne diseases, vector-borne diseases, and definitely with COVID too. Now we're seeing this same kind of presentations with long COVID, and it's like, oh my gosh, so eerily familiar to me, where these patients don't know where to go. It's a chronic infection. Doctors are not educated about it. The average person doesn't know how to test. There is no real test for chronic COVID. So many question marks, so few answers. And I'm just kind of curious about your take on that whole picture.
So in terms of kind of giving some inspirational stories, definitely have had a number of them. One that comes to mind would be, I think she came to me when she was just in high school, and she started having seizures and was not able to go to school. Over the years, she was doing IVIG and antibiotics for a number of years. All of that basically with the diagnosis of encephalitis, infections induced encephalitis with Lyme, Bartonella, and Babesia, and we treated her for that, and she went on to live, to move out of her house, go to college, and has, I think last year, graduated from MIT PhD. She got a PhD from MIT, and she's working in neurosciences. I believe she's working on field mice as to how to prevent them from transmitting Lyme to the ticks.
Oh, I love her. Oh my,
Yes.
tell her thank you from all of us
Yes.
in the Lyme world. That's
Yes.
awesome. You must be so rewarded. I know you are, because I have to tell you the cutest little story is that several years ago, I sent you a young boy. I think you probably know, and the parents
Mhm.
from Manhattan. And
Mhm.
I was sitting down. I think when I sent him to you, maybe he was like 13. And I was sitting. He's the sweetest child. I love him. I've known him since birth because I went to college with his mom, and I've known them forever. And we were having dinner at his house one night, and he was kind of like shyly looking down at his food, and he wanted to tell me something, and I'm waiting for it, and he looks up, he goes, Dana, thank you so much for Dr. Frid. Thank you. She's helped me so much. I love her. And
Thank
he
you.
said, what stood out to me is he said, you almost cried when he got better. You were so happy and overjoyed. He went back to school, and he just, all of his like really bad symptoms resolved. And he'd been suffering for a really long time. And he said, you really cared about getting him better. And
Yes.
it meant, you may think like, does anybody even know? Do people realize how much, I'm putting into all of this? And I just want you to know, like, that's what came back.
Thank you.
So, I mean,
Yes.
what's better than that? It's just
It's incredible. I
yeah,
love that when people are basically coming in and leaving our practice, becoming the best versions of themselves and kind of
yeah.
living their dream. That's the best reward.
I can only imagine. Yeah, and it's just so difficult to go through these things, and people don't realize the trauma for the entire family.
Agreed.
No matter who, and often there are multiple people sick in the same family because they're sharing environments. And I think it's really under-recognized. And it's even under-recognized that people think, okay, I took the 2 weeks of doxy and I'm fine. I don't know what the big fuss is, but actually they're not fine. And what happens is there's a latency period between the rest of the symptoms coming back that can last weeks, months, even years. And we know that. Nobody traces it back. Often people, including mostly physicians too, just don't trace it back. So people will say, I'm fine, but I have fibromyalgia. Well, why
Yes.
do you have fibromyalgia? You didn't have
Right.
that before the tick bite 9 months ago.
Hmm.
And people don't realize these things are all interconnected at times. I think it's really important to talk about the role of toxic mold because nobody talks about it. There's so much literature on it. And it's one of these deeply hidden things. And I think it's probably because it's so common. It's really expensive to fix. And insurance companies took it out of their policies in like the early 2000s because they were having to pay out these incredible, enormous sums to homeowners who got sick in mold infested houses. What do you think the role is of toxic mold in chronic illness and neurological diseases?
Right. So I think that that was actually one of the other things I was going to touch on. When patients don't tolerate treatment, when they come in, you start them, let's say, innocently on a doxycycline or an oil of oregano or something like that. And all of a sudden they have these violent reactions. They can't tolerate things. They're really not getting better, meaning those Herx reactions, or what you think are Herx reactions, don't get better within days or a few weeks. Most likely they have an environmental toxin where their body basically is overwhelmed with A, pathogens, and B, toxins. And when you're killing off these infections or trying to, it overwhelms your immune system even more. And they basically get sick, toxic from it.
Yeah,
And so that's when I definitely look into the mold component. As you said, it's really hard to treat because
yeah,
to get somebody out of their moldy house,
yeah.
it's a lot. But you can't treat the mold if the patient constantly is being exposed
I
to it in
know.
their home.
But people can remediate, they can,
Yes,
if it's a leak that came from one source and they can get it remediated and at least clean up the majority of it. I think I've definitely heard of people being able to tolerate, their environment with some detoxing. I mean,
mhm.
subscribe to any of that? Do you think that's like a fair thing to try if you can afford to
If you
cut out the bathroom ceiling and replace it?
absolutely, just
Yeah.
make sure that you're doing it properly, meaning so that it doesn't infest the rest of your home. The
Yeah.
contractor needs to be aware of how to kind of protect the rest of the house when they're remediating your home. And the other interesting part is, even if you move out of that home, some patients may continue to have the toxins floating around in their body. So as you said, you do need to detox them.
What do you do? What are some strategies people can do?
So a lot of times it's going to be starting with binders. That's what you start doing. The other thing is, again, modifying the diet would be important as well. In my
Do you mean
opinion,
taking like grains out and foods that have certain
yes,
are more susceptible to mycotoxins and
right.
mold?
I don't love peanuts.
Yeah.
I
Yes.
think they do have a considerable amount of mold,
Yeah.
or they can trigger your allergens to other foods.
Yeah.
So that would be something to consider kind of taking out of your diet.
Are there other things we can do dietarily just to reduce inflammation and things that may be good for the brain specifically?
Yes, so I generally recommend to have a low anti-inflammatory diet, which would constitute reducing gluten, reducing dairy, and refined sugars.
Okay.
So that's basically the recommendation. Usually, again, because we're talking about kids, it may be an uphill battle to try to get them off of that.
Yeah.
I would say give it a couple of weeks. If you're not seeing major changes in their clinical symptoms, I would say probably not going to give you a huge benefit in improvement. So you'll need to address it in other ways as well.
What's the first step if you have a child that has possibly like a new onset of neurologic or neuropsych stuff and body pain, all the kind of things that we have talked about and that you see? Where do they go? What's the first step?
Right. So I would say you go to see your pediatrician, get a workup. I think it's very important to make sure that we're not missing, an underlying issue that's going on with them. Family history. Have you had this before? Think back about what could be a trigger. Has it been a virus that they had recently, or maybe there was strep going around at school, and then a week later your child kind of started feeling much worse. So try to think about what could be going on, or what could be the trigger.
Great.
See your pediatrician, do a workup there. If they're saying, everything's normal, but you see your child is, not doing well at all,
Right.
That's when I would probably seek out a specialist and see if there's an underlying medical problem that is not detected by your regular pediatrician.
I know that this podcast is going to create a lot of interest in people seeking you out specifically. And I want to know, are you taking new patients? How can people, do you have talks or a website that people can go and learn more and just learn more from you?
Yes, so our website is lidamedical.com, Lida, Leda medical.com, or you can go to elenafridmd.com. So either one of those, you can reach out to our office. In terms of new patients, we have a wait list, but you can submit your information and you'll get someone from the office will get in touch.
Now with COVID hitting the world, I think you must be even busier because of all the neurologic conditions that COVID can cause, that COVID can combine with and cause, COVID can reactivate latent infections and cause. So I think we're just dealing with this whole toxic stew of infections and environmental factors.
Correct.
Yeah. Well, thank you. I love talking to you. You are a wealth of brilliant information, and I really, really appreciate everything that you do. Thank you.
Dana, thank you for for doing what you do. You're educating all these people and doing an incredible job. So thank you.
Thanks. I'll speak to you soon. Thank you for joining us for this episode of Ticktective, a program of the Bay Area Lyme Foundation. For more information or to get involved, please visit us at bayarealyme.org.